So before we start, let me first introduce myself. My name is Ahmed. I'm a medical grad from Egypt. I passed my Step 1 exam and the Step 2 CK with 261 score. I have been tutoring for 3 years now, Step 1 and the Step 2 CK. So today's section is dermatology. We will try to cover the highest yield concepts in the dermatology. We will cover the skin cancers. We will cover the bullous diseases, the hair loss diseases, and the foot ulcers. So first we will go through a PowerPoint, and after that, at the end of the session, we will go through some questions from our Synapse QBank. So you guys are welcome to ask any questions between each section. So after finishing the skin cancer, you can type your questions in the chat, okay? So let's start. Okay, so we will start with the skin cancers. So usually for the skin cancers in the Step 1 exam, he will give you a picture or a description of the cancer. And after that, he might ask you about the histology or the risk factor for this cancer. So let's start with the basal cell carcinoma. So how would he describe the basal cell carcinoma in the question? He will tell you that we have a pearly lesion in the face or any sun-exposed area. And on this pearly lesion, we have telangiectasias. So what is telangiectasia? They are basically small blood vessels under the skin, okay? So this is the description of the basal cell carcinoma. So what would be the histology for basal cell carcinoma? So obviously for basal cell carcinoma, we might find basaloid cells. Makes sense, basaloid cells for basal cell carcinoma. What else? We might see a pattern called palisading, exactly, pattern. So what is palisading pattern? How would it look like? It would look like a tumor nest surrounded by the tumor cells. Okay, so the thing at the center is the tumor nest. Pay attention, guys. We have another histology in the USMLE called pseudo palisading, pseudo. And this is basically a center of necrosis surrounded by the tumor cells. Can someone tell me the pseudopalisading is the histology for which condition? Amazing. Glioblastoma. Okay, which is basically a tumor from the astrocytes in the brain. Nice. He might ask you about the risk factor for basal cell carcinoma. So what is the risk factor for basal cell carcinoma? Obviously, sun exposure. In other words, ultraviolet rays. Okay, exposure to ultraviolet rays. All right, so this is a picture for basal cell carcinoma. It looks pearly, glistening, with small blood vessels. These are the telangiectasias. Okay, these are the telangiectasias. All right, so what about squamous cell carcinoma? How would he describe squamous cell carcinoma? He will tell you that we have a non-healing ulcer on the nose or any sun-exposed area. And this ulcer has lots of scales on top. Okay, so this would be the description for squamous cell carcinoma. What about the histology of squamous cell carcinoma? Very high yield. The histology is the keratin pearls, very important, and intercellular bridges. So keratin pearls looks like holy masses like this, and intercellular bridges is basically, so let's say that these are the keratinocytes in the epidermis. Between these keratinocytes, we have desmosomes, guys. We also call them intercellular bridges. So in squamous cell carcinoma, we will have lots of intercellular bridges, okay? Nice. So what would be the risk factor for squamous cell carcinoma? Again, sun exposure. but we can have also lots of risk factors. For example, HPV, strains 16 and 18. Human papillomavirus, strains 16 and 18. They also can cause squamous cell carcinoma. Okay. What else? We might have squamous cell carcinoma if the patient is immunocompromised. So for example, if he give you a patient who just had a transplant, okay, and now he is on immunosuppressant medications, okay, and this patient developed non-healing ulcer. So think of squamous cell carcinoma, all right? What else is a risk factor for squamous cell carcinoma? Amazing. So actinic keratosis. So actinic keratosis, guys, is a pre-malignant lesion for squamous cell carcinoma. So how would it present? He will tell you that we have a farmer or a construction worker presenting with rough skin or sandpaper skin. So why would the occupation matter? Like, why is he telling me the occupation? Farmer or construction worker? These patients or these occupation have lots of sun exposure, lots of ultraviolet exposure. So he's basically saying that this patient had lots of sun exposure and now presenting with rough skin or sandpaper skin. This is how you know this patient is having actinic keratosis. Then he might ask you, this patient is at increased risk of which of the following? And the answer would be squamous cell carcinoma. Okay, nice. Okay, this is the non-healing ulcer for squamous cell carcinoma, and this is the keratin pierce, okay? Keratin pierce is associated with any squamous cell carcinoma. Squamous cell carcinoma of the skin, of the oral cavity, of the tongue, of the lung, around the anus, okay? If you take any biopsy of any squamous cell carcinoma, you will see the keratin pierce. All right, what about melanoma? So how would he describe the melanoma in the question? He will describe it as A, B, C, D, E. Okay, so A for the asymmetry. So asymmetry meaning the right side, of the melanoma won't look like the left side. Okay, they are asymmetric. B for irregular borders. The borders are irregular. Okay. C for colors. We will have lots of color variation. Brown, black. D for diameter, more than 6 milli. If the diameter is more than 6 milli, this is a sign for melanoma. And E for evolution over time, meaning the patient will tell you that this lesion is getting bigger. It wasn't the same as last year. Okay, so this is also a sign for melanoma. So what would be the histology for melanoma? Obviously, you will see immature melanocytes. Okay. What about the risk factor? Again, the risk factor would be sun exposure. All right. So you need to know, you need to be familiar with two things about the melanoma, or two types about the melanoma. The first type is called acral lentiginous, and the second is called lentigo malignant. So acral lentiginous is a melanoma that arises in the palms and soles. Okay, palms and soles. Palms and soles are not exposed to the sun, guys. Okay, so acral lentiginous is not associated with sun exposure. So it arises in palms and soles in patients of dark skin, like African Americans, for example. Okay, amazing. Lentigo malignant, on the other hand, is basically melanoma in situ. So melanoma in the epidermis, not invading the basement membrane. And it arises in all the patients with lots of sun exposure, okay? With lots of sun exposure. So what question he might also ask about the melanoma? He might ask you, what is the most important prognostic factor of melanoma? So what is the most important prognostic factor of melanoma? The answer would be the depth of invasion. And he might also tell you that not the depth of invasion, he will tell you vertical invasion. It gives the same meaning, okay? So if this is the surface of the skin, we have a melanoma over here. Vertical invasion meaning invasion like down, okay? This is the vertical invasion. We also might have something called radial invasion, which is invasion of the superficial layers. So obviously the vertical invasion is much worse than the radial radiation because vertical can increase the risk for metastasis. Okay. So can someone tell me melanoma metastasizes to which organs? Amazing, Drasusi, amazing. Brain and lung. Okay, this is very important. All right. So this is how melanoma looks like. Lots of colors with irregular border. And this is the acral lentiginous. Okay, so a melanoma in the palms and soles in dark-skinned population. All right, this is a table differentiating between the basal cell carcinoma, squamous cell carcinoma, and the melanoma. Okay, so in melanoma also, guys, we might have another risk factor for melanoma is BRAF V600 mutation. Okay, BRAF V600 mutation. This could be also a risk factor for melanoma. Okay. Okay, let's go over the bullous diseases. So bullous diseases, they usually give you the appearance of the blisters, and then he will ask you about, okay, which point, Niha? If someone needs anything about the skin cancer, this is the time to ask, guys. Okay, so I believe you are talking about the PREF V600. Yes. So if someone has a PREF V600 mutation, he can have increased risk for melanoma. Okay. So squamous cell carcinoma is associated with patients who are immunocompromised. Patients who are immunocompromised can't get rid of some of the cancer cells in the skin. And most of the cancer that arise in the skin in patients who are immunocompromised is squamous cell carcinoma. You just need to know that, okay? Exactly. All right, so let's start with pemphigus vulgaris, which is one of the bullous diseases. So what is the cause of the pemphigus vulgaris? What causes pemphigus vulgaris? So pemphigus vulgaris is a type 2 hypersensitivity reaction, meaning we will have auto antibodies. So these auto antibodies will destroy the desmoglein. Okay, desmoglein 1 and desmoglein 3. So again, let's say that these are the keratinocytes in the epidermis. Between these keratinocytes, we have the desmogleins that bind these keratinocytes together. If we have autoantibodies against these desmogleins, the keratinocytes will start separating from each other. We call this acantholysis. Okay, acantholysis. So this is the histology in patients with pemphigus vulgaris. Okay, so if we have autoantibodies against desmoglein 1 and 3, we will have affection of the skin and the mucous membranes. Okay, so the skin has desmoglein 1 because it is the biggest organ, and desmoglein 3 is in the mucous membrane. So you can't have a patient with pemphigus vulgaris who has mucosal sparing. So once you see in the question that he says that this patient is having mucosal sparing, the answer is not pemphigus vulgaris. Okay, is that clear? Okay, so when the keratinocytes separate from each other, they will form a blister, and this blister is very weak. So once you apply pressure to these blisters, they will rupture, meaning pemphigus vulgaris is Nicoleski positive. Okay, Nicoleski positive, meaning the blisters are very weak and they can rupture. All right. So can you see this guy? So he doesn't have any blisters. Okay, why? Why this guy doesn't have any blisters? Because they are very weak and they ruptured. All right. Nice. He might give you this picture, which is the immunofluorescence picture in patient with pemphigus vulgaris, and it looks like reticular. It has a reticular shape or fishnet shape. And it makes sense. The immunofluorescence dye binds to the autoantibodies, and the autoantibodies are between the keratinocytes because they are attacking the desmoglein, which is between the keratinocytes. That's why the dye will be deposited around or between the keratinocytes, causing the reticular shape. Does this make any sense? Nice. All right, let's move on to the bullous pemphigoid. So what is the cause of the blisters in patient with bullous pemphigoid? Again, this is type 2 hypersensitivity reaction. So we have O2 antibodies. These autoantibodies are directed towards hemidesmosomes. Okay, so the hemidesmosomes are the proteins that bind to the epidermis to the dermis. So if we have autoantibodies against these, the epidermis will separate from the dermis, and we can have blisters between them. If you notice, guys, the roof of this blister is the whole thickness of the epidermis. It means these blisters would be very tense, very hard to rupture. That's why bullous pemphigoid would be Nicoleski negative, okay? Nicoleski negative. Again, why? Because these blisters are very tense and very hard to rupture. Amazing. So what else can we differentiate between bullous pemphigoid and pemphigus vulgaris? I told you guys, in pemphigus vulgaris, we have mucosal involvement. In bullous pemphigoid, the mucosa is spared. Okay? This is very important. So now we have the mucosa and the Nicoleski. You can use these to differentiate between the bullous pemphigoid and the pemphigus vulgaris. Nice. As you can see, this bulla looks very tense. Okay. And this is the separation between the epidermis and the dermis. So if you look here, we don't have any separation. But here, the epidermis separated from the dermis, and we will have fluid accumulation, which will cause the blisters. Okay. And that's why the immunofluorescence dye in patient with bullous pemphigoid would be linear, because the dye will be deposited at the site of the autoantibodies, and the site of autoantibodies is linear, okay, between the dermis and the epidermis. Is that clear, guys? Nice. Okay, so now let's talk about the Stevens-Johnson syndrome. So this is also a syndrome that can cause blisters, and it's basically a type 4 hypersensitivity reaction. We have the T cells attacking the skin and mucosa causing necrosis. So you need to know that these reactions happen after a medication intake. Certain medications can cause Stevens-Johnson syndrome. Can someone tell me examples for this medication, guys? Amazing. Sulfa medications. What else? Allopurinol, which is a gout medication. What else? Lamotrigine. Amazing. Very important medication. Phenytoin or carbamazepine. Okay, so whenever he give you a presentation, a patient who just had a phenytoin and after a couple of days he presented with sloughing of the skin and mucosal ulceration. And he might tell you also that upon lateral pressure on the blisters ruptured. So this means that Stevens-Johnson syndrome is Nikolsky positive. Okay, Nikolsky positive. Nice. So guys, if the skin involvement is less than 10% of the surface area, we call this Stevens-Johnson syndrome. Okay, but if it is more than 30%, we call this 10 toxic epidermal necrolysis. Okay, toxic epidermal necrolysis. It is the same as Stevens-Johnson syndrome, but the difference is the surface area affected. All right. Okay, as you can see, this patient, he has skin involvement and mucosal involvement. Again, you can't have Stevens-Johnson syndrome without the mucosal involvement. All right, so now let's talk about the staphylococcal scalded skin syndrome. So what is the cause of the blisters in staphylococcal scalded skin syndrome? It's caused by a Staph aureus infection. This Staph aureus will make a toxin called exfoliative toxin. Okay, from its name, exfoliative toxin, it will cause exfoliation of the skin. So it will cause separation of the skin or of the epidermis at the corneal or the stratum corneum. So stratum corneum, guys, is the most superficial layer of the epidermis. Okay, so this will separate from the rest of the epidermis. All right, this happens in staphylococcal scalded skin syndrome. So if the roof of the blister is only the stratum corneum, which is very thin, this blister can rupture very easily. So again, staphylococcal scalded skin syndrome is Nikolsky positive. Okay, amazing. As you can see, this patient had blister, but since they are very weak, they ruptured. Okay, and this is a hand of a baby because the staphylococcal scalded skin syndrome cause infections in the neonates or immunocompromised adults. Like, for example, patients with renal failure. Okay. Nice. Now let's talk about epidermolysis bullosa. Okay. So epidermolysis bullosa also can cause blisters. So what is the cause of the blisters in epidermolysis bullosa? The cause is mutation in anchoring proteins. For example, laminin and keratin. Okay, mutation in the anchoring proteins. So it can cause blisters, and the blisters here are also Nikolsky positive. So I see lots of students mix up between epidermolysis bullosa and the staphylococcal scalded skin syndrome, because usually both of them present at a very young age in the neonate or something like this, but they are completely different. Epidermolysis bullosa is something genetic. It's a mutation caused by mutation in anchoring protein. But staphylococcal scalded skin syndrome, this is an infection with Staph aureus, okay? And another key sentence for epidermolysis bullosa, like once you see it or you read it, you know they are talking about the epidermolysis bullosa. He will tell you that this patient had blisters after trauma. Okay, blisters after trauma or microtrauma. That's why the presentation of epidermolysis bullosa would be at the lower extremities of the children, because these are the most area of the body susceptible to traumas, okay? And as you can see, the blisters here are ruptured because they are very weak, Nicoleski positive. Is that clear, everyone? Nice. Okay, so this is a table differentiating between all the bullous diseases. And this is another table differentiating between them based on the Nicoleski and the mucosal involvement. So the only bullous disease here that is Nicoleski negative is bullous pemphigoid. Okay, the blisters are very tense and very hard to rupture. The diseases with mucosal involvement are the pemphigus vulgaris and Stevens-Johnson syndrome, which is basically toxic epidermal nucleolysis. Is that clear? We already mentioned what is important here, Amrit Pal, okay? Okay, this is the previous slide. Someone wants to take a screenshot. Nice. So now let's talk about the diseases of the hair loss. And for the hair loss, guys, they will also, in the question, they will also give you like a picture or a description of this hair loss. And then he might ask you about the cause or the treatment of this hair loss. All right. This is the table again, guys. Okay, Sergio. All right, so let's start with androgenic alopecia, which is the most common cause of hair loss. Probably we know someone that someone's head that looks like this. So this is probably someone in your family or my family. It can be also you. I don't know. So these patients with androgenic alopecia, they have hair loss in the frontotemporal areas and the vertex. Okay, this is the distribution of the androgenic alopecia. So why androgenic alopecia happens? Why? Because of an increase in a hormone called DHT, dihydrotestosterone. Okay, so we have a hormone called testosterone, and this testosterone can be converted into DHT by an enzyme called 5-alpha reductase. Okay, so if we have increased conversion of the testosterone into DHT, this can increase the DHT level, and it can cause androgenic alopecia. Pay attention, guys. Increased DHT also contribute to benign prostatic hyperplasia and prostate cancer. That's why the treatment for androgenic alopecia, benign prostatic hyperplasia, or prostate cancer would be 5-alpha reductase inhibitors, like finasteride, for example. Okay, so finasteride inhibit this enzyme and decrease the conversion of testosterone to DHT, and this will decrease the size of benign prostatic hyperplasia, decrease the size of prostate cancer, and increase hair growth. Okay. Another medication that we can give for androgenic alopecia is minoxidil. Again, you probably know someone who was on minoxidil and it didn't work. I know it didn't work. Okay. So how does minoxidil work? How does minoxidil work for patients with androgenic alopecia? They cause vasodilation of the blood vessels going into the hair follicles. So by doing that, you are increasing the nutrient to the hair follicles. And in step 2CK, guys, you will know that minoxidil isn't given alone in males, okay? Because it is only an adjunctive therapy. It is an adjunctive therapy, okay? So the first line medication for androgenic alopecia in male is finasteride, and you can give minoxidil with it as an adjunctive therapy. So if you have someone in your family who's only taking minoxidil, tell him you will lose all your hair, okay? And for me, the first line medication for androgenic alopecia is a travel to Turkey. This is the only way that you can get your hair back, okay? Or you can just like live in delusion and say, I love my bald hair. All right. The second cause of alopecia areata, the second cause of hair loss is alopecia areata. So what is alopecia areata? This is a type 4 hypersensitivity reaction. So type 4, we have the T cells attacking the hair follicles. So what would be the picture for alopecia areata, or the description for alopecia areata? He will tell you that we have well circumscribed patches of hair loss. Okay, as you can see, these are well circumscribed patches of hair loss. Okay. He might also tell you that when we took a hair follicle from the periphery of these patches, we found exclamation mark shape of the hair follicle. So what does exclamation mark shape of this hair follicle? It means that it's very thin at the base and very wide at the distal end. Okay, so these are the hairs that are found in the periphery of the patches in patient with alopecia areata. So what would be the treatment for alopecia areata? Obviously, this is an autoimmune condition, so the treatment could be topical corticosteroids, and we can also give minoxidil. And by the way, guys, since alopecia areata is an autoimmune condition, in the questions, he will mention a history of other autoimmune condition. For example, he will tell you that this patient is having a history of Hashimoto's disease or type 1 diabetes mellitus or vitiligo, exactly. Okay, nice. Now let's talk about the trichotillomania. So what is the cause, or what is trichotillomania? This is basically a repetitive hair pulling pattern. Okay, so why would the patient pull his hair? This is a good question. Why would he pull his hair? Exactly, this is a psychiatric condition. The patient feels a relief after he pulls his hair. Okay, so since it's a psychiatric condition, it would be associated with other psychiatric conditions, like for example, depression, OCD, or anxiety. Okay, and since it's a psychiatric condition, the treatment for it would be cognitive behavioral therapy and SSRI. Okay, nice. So what would be the picture or the hair loss distribution in patient with trichotillomania? He will tell you that we have irregular, irregular patches of hair loss. And then he will tell you that we also have hair of varying degrees of length. Okay, hair of varying degrees of length, meaning that the patient pulls the hair at different time. So this is how we differentiate it from alopecia areata, for example. In alopecia areata, we had well circumscribed patches of hair loss. You won't find any hair in these patches, okay? You won't find any hair. But in case of trichotillomania, we will have irregular patches, and even in these patches, you might have some hair, but at varying degrees of length. Is that clear, everyone? Okay. Now the last cause of hair loss, which is tinea capitis. So what is the cause of hair loss in tinea capitis? The cause would be infection by dermatophyte, like microsporum, for example. Okay, dermatophyte or microsporum. It will infect the scalp and it will cause hair loss. Okay. So what would be the presentation for tinea capitis? He will give you a picture like this, in which we will have a hair loss and lots of scales, as you can see. And also, he will tell you that uh, um, that the patient is feeling very itchy at this site. Okay, so it's very, very itchy. And sometimes he might also mention occipital lymphadenopathy. Okay, so occipital lymphadenopathy, meaning that in this part, there is probably lots of inflammation and infection. Okay, exactly, Carol. So he might also mention that we have like black spots at this area, and these black spots are basically the hair follicles. Okay, the hair follicles. Nice. So what would be the treatment for tinea capitis? What is the treatment for tinea capitis, guys? Amazing. So for any tinea in the body, in the feet, you can give topical antifungals. But in case of tinea capitis, the topical antifungals can't penetrate very well into the scalp. So we must give oral antifungals. For example, like griseovolvin or terbinafine. Can someone tell me what is the mechanism of action of griseovolvin? Oh my God, amazing. So microtubule inhibition. So microtubule is important for the fungal division. Okay. So if we stop this, we won't be making any like fungal division. All right. So what is the mechanism of action of terbinafine? Very fast. What is the mechanism of action of terbinafine? Amazing. So inhibition of an enzyme called squalene epoxidase. Okay. So this is an enzyme that is important for the cell membrane synthesis. Why I'm telling you that, guys, because he might give you a presentation for tinea capitis, and then he will tell you that we started an oral medication for this patient. This oral medication works via which of the following mechanism? And the answer would be microtubule inhibition or squalene epoxidase inhibition. Okay, is that clear? Very nice. So this is a table comparing between all the types or all the causes of hair loss that are high yield for the USMLE. Any questions so far? All right. So let's finish with the foot ulcers. So in the foot, we can have ulcers because of arterial damage. This will be arterial ulcers, or because of chronic venous insufficiency, venous ulcer. Okay. What else? Exactly. In patient with diabetes mellitus, for example, neuropathic ulcer. Hmm, amazing. Or pressure ulcer. So how can we differentiate between these based on the location in the feet? So arterial ulcer arises in the chin of the tibia, the dorsum of the feet, or the tips of the toes. Okay, so like it is basically on the dorsum. Okay, the dorsum, the chin, the dorsum of the feet, and the tips of the finger. With the arterial ulcer, also, he might tell you that this patient has hair loss in the lower extremity or absent pulse. So these are signs for arterial damage. Okay, signs for arterial damage. What about the venous ulcer? What is the location for venous ulcer? So venous ulcer arises near the medial malleolus. Near the medial malleolus, okay? And he might tell you that this patient has a history of chronic venous insufficiency, okay? Or he might tell you that the skin in the lower extremity for this patient is very brownish. Why? Because the patient with chronic venous insufficiency will have hemosiderin accumulation exactly in the skin. Amazing. All right, what about neuropathic ulcer that happen in patient with diabetes? So patient with diabetes, mostly they have like peripheral neuropathy, okay? And any patient with peripheral neuropathy, when he walks, he can't feel his feet hitting the ground. That's why they will start walking like this, so that they can feel the ground. And this walking can cause microtrauma at the sole. And this microtrauma can cause ulcers at the sole of the feet. Okay, so the neuropathic ulcer would arise at the sole, specifically at the base of the big toe. Okay, base of the big toe. Nice. What about the pressure ulcer? So pressure ulcer, this happens in patients who are bedridden. Okay, exactly. They are immobile. They are bedridden. So if this patient is bedridden, guys, what is the most dependent part? The most dependent, the closer to the gravity. No, no, I'm talking about the foot, the feet. Exactly, this part over here, which is the skin under the calcaneus. Okay, exactly, the heel. So this would be the place for pressure ulcer. So this is how you can differentiate between the foot ulcers based on the location. Any questions so far? No, they don't have to present bilaterally. Okay, very nice. Okay, this is a table differentiating between all the types of ulcers. You can take a screenshot right now, guys. Nice. So let's start with our questions from the Synapse QBank. Okay, so let's go through this question. A 54-year-old man comes to the physician because of dark, irregularly bordered lesion on his upper back. Physical examination shows a 1.2 variegated plaque with asymmetric border on the right scapula. There is no palpable lymphadenopathy. An excisional biopsy performed which revealed asymmetric proliferation of atypical melanocytes. So now I know he's talking about melanoma. He's asking which of the following is the most important prognostic factor for this patient overall survival. We said that the most important prognostic factor is the depth of invasion, exactly, or the vertical invasion, not the radial, not the radial. For sure, for step 1 and 2, this concept. Okay, nice. All right. This patient is a 24-year-old woman brought to the emergency department because of 1 day history of fever, chills, vomiting, and watery diarrhea. She reports that her symptoms began suddenly this morning. Her medical history is unremarkable. She is currently on her 4th day of menstrual period. She appears lethargic and ill. There is a diffuse erythematous rash on the entire body, including the palms and soles. The oropharynx is also hyperemic. Which of the following mechanism best explain the pathogenesis of this patient condition? Can someone tell me what is this presentation? It is not very clear, to be honest. Amazing. Toxic shock syndrome. Okay. This patient is presenting with toxic shock syndrome. So this is caused by a Staph aureus infection. The patient will have fever, rash, hypotension. So what is the cause of all these symptoms, guys? The cause is something called super antigen. So the super antigen is an antigen that can bind to the T cell outside the antigen binding groove. So this will cause lots of cytokines release from the T cells. We call this cytokine storm. And the cytokine storm is what actually caused all this presentation, the fever, the rash, okay, and the hypotension. Exactly. So this patient presented with rash in the palms and the soles. Can someone tell me the other causes of rash in palms and soles? Hmm. Okay, amazing. Second, don't say syphilis, secondary syphilis. Okay, secondary syphilis. What else? Rocky Mountain spotted fever. Nice. What else? Hand, foot, mouth disease. Amazing. Another one. Coxsackie is the hand, foot, mouth disease. Okay, amazing. We mentioned those. Okay, the last one is a patient that is only diagnosed if we have fever more than 5 days. Exactly, Kawasaki. Excellent. All right. What is this picture? I don't have to go over the question. What is the picture? The holy lesions in whatever part. I don't care in the skin, in the lung. Exactly. This is a squamous cell carcinoma. So the most likely diagnosis is squamous cell carcinoma. All right. A 24-year-old woman comes to the physician because of a rash on her chest and back that developed over the past 5 days. She reports that the rash is mildly itchy, but she has no pain. She noticed a single large red spot on her abdomen 2 weeks ago, which she initially attributed to bug bite. Physical examination shows a solitary 4 cm salmon-colored plaque with peripheral rim of fine scale. The back and the chest demonstrate multiple widespread from half centi to 1.5 centi oval erythematous macule and papule. So this patient presented with a large lesion, 4 centi lesion, okay, erythematous lesion, and then she developed a smaller lesions. Exactly. So he mentioned salmon colored plaque here because he knows that salmon colored is always like psoriasis in whenever you read it you think of psoriasis, but we don't have any psoriasis here. And even if we did have psoriasis, it won't be the correct answer. Amazing, guys. So this patient is presenting with Theriasis rosea. Okay, Theriasis rosea. So patient with the Theriasis rosea present with a big rash or a big lesion at first. We call this the herald patch. After that, they will have smaller lesions, okay? And it will cause like the Christmas tree appearance on the trunk or on the back. So what is the organism causing the Theriasis rosea? Don't tell me HHV. Exactly, 6 and 7. HHV 6 and 7. Amazing. All right. What about HHV8? Exactly, it causes Kaposi in patient with HIV. All right. Also be familiar that uh, with also be familiar with a condition called roseola infantum. Okay. So rosula infantum is a condition that can also happen because of HHV 6 or 7. So how would you spot rosula infantum in the question? Whenever he tell you that this neonate developed fever, then this fever subsided, and now he's presenting with rash. Okay, exactly. So rash after a fever, rash after a fever. This is rosula infantum, and he might ask you about the organism. It's HHV 6 and 7. Amazing. Okay. A 76-year-old man comes to the physician because of 3-week history of severely pruritic rash on his abdomen and inner thigh. He reports that the rash initially spread as red hive-like patches, but has since developed into large fluid-filled blisters. Physical examination shows multiple large tense pulli, firm sliding pressure on the thumb on unaffected skin near the lesion doesn't result in detachment of the blister. So it means that this patient is having Nicoleski negative. We only mentioned one condition that has Nicoleski negative today, which is the bullous pemphigoid. Okay, bullous pemphigoid. So bullous pemphigoid is caused by autoantibodies against which of the following? Amazing. Exactly. Hemidesmosomes. Okay, hemidesmosomes. Autoantibodies against type 4 collagen will cause which condition, guys? Amazing, excellent. Good Basher syndrome. Okay, these patients will present with hematuria and hemoptysis. Hemoptysis. Okay, antibodies or autoantibodies against tissue transglutaminase will cause which condition? Exactly, celiac disease. IgA antibodies. IgA antibodies. All right. So this patient is presenting with hypopigmented patches. Okay, so it could be like vitiligo or psoriasis versicolor. So let's see. From first look, it looks like psoriasis versicolor, but let's see. A 26-year-old woman comes to the physician because of 3-week history of pale spots on her chest and back. She first noticed the lesion after returning from a beach vacation. So she probably had a tan, and the tan affected the normal skin, but not the diseased one. After she spent most of her time outdoor, the lesions are asymptomatic and do not itch, but the patient is concerned because they didn't tan along the rest of the skin. She has no significant past medical history and takes no medication. A fine dust-like scale is noted. So this patient is having a scale in these lesions. So it is probably not vitiligo, okay? This is probably Theriasis versicolor. So which of the following mechanism best explain these findings? So Theriasis versicolor is caused by Malassezia furfur infection. The Malassezia furfur infected the superficial layer or the stratum corneum of the epidermis, and it decreases the activity of an enzyme called tyrosinase. This is the enzyme that converts the tyrosine into melanin. So by decreasing the activity of the tyrosinase, this will decrease the melanin. And the patient will present with the hypopigmented patches. So in KOH preparation of these lesions, what you will find spaghetti and meatball appearance. Okay, spaghetti and meatball appearance. All right, nice. So what would be the treatment for Malassezia furfur? So for the treatment, we can give ketoconazole, which is an antifungal, or selenium sulfate. These two medications can kill the Malassezia furfur and can also cause shedding of the superficial layer of the skin in which the Malassezia furfur stay in. Is that clear? Nice. Okay, so the correct answer would be inhibition of tyrosinase by fungal metabolite. Okay, autoimmune destruction of melanocytes. This would be which disease? Usually in a shampoo form. Okay, fire? Exactly. Autoimmune destruction of melanocyte. This is the correct answer for vitiligo. Okay, vitiligo. Okay. A 52-year-old African American man comes to the physician because of dark spot on the bottom of his right foot. He says that it has slowly enlarged and has recently become more irregular in shape. Medical history is unremarkable. Physical examination shows a 1.6 asymmetric dark brown to black macule on the plantar surface with irregular border. So this is clearly a melanoma. And what melanoma arises in the palms and soles? Exactly, acral lentiginous. Okay, and he mentioned that this patient is an African American. Okay. A 74-year-old man comes to the physician for a routine skin examination. He is a retired farmer who spent the majority of his career working outdoor in the Midwest. Okay, so it means that he had lots of sun exposure. He reports no specific concerns but notes that several rough spots on his forehead and scalp have been persistent for the past year. So he's probably talking about actinic keratosis. Physical examination shows multiple 4 to 6 milli ill-defined erythematous plaques with great scales. Which of the following finding would most likely be observed on histologic examination of a biopsy from one of these lesions? Okay, amazing. So let's try to eliminate, guys. First of all, nest of basaloid cells with peripheral palisading. This is the answer for which condition? Exactly, basaloid cells, peripheral palisading. This is basal cell carcinoma. Okay. Epidermal hyperplasia, elongated reed ridges, and Monroe microabscess. Neutrophilic accumulation in the epidermis. This is the correct answer for which condition? Exactly, psoriasis. Okay, this is the correct answer for psoriasis. Okay. Keratin-filled pseudocyst and stuck on appearance. Seborrheic keratosis. Okay, stuck on appearance. Brownish macule that have the stuck on appearance. Um, and by the way, we can have like sudden multiple seborrheic keratosis in the body. We call this the Lissert-Relay sign. And this could be a sign for GI malignancy. Very important. All right. Full thickness epidermal atypia with intact basement membrane. Okay, so I would choose between this and this, but I would also honestly go with E, partial thickness. Yeah, so this could be like since he mentioned atypia, so this could be a cancer, and it could be squamous cell carcinoma. So I would go with like partial thickness. Okay, exactly, squamous cell carcinoma in situ. So I would go with that. Let's see. Nice. Okay. Yeah, and the parakeratosis can also be the histology in patient with psoriasis, by the way. Parakeratosis, guys, is the retention of the nuclei in the keratinocytes in the superficial epidermis. So usually the keratinocytes in the superficial epidermis shouldn't have any nuclei. But if we have parakeratosis or retention of nuclei, this could be like a sign for example, psoriasis or actinic keratosis. Okay. All right. Last question. A 74-year-old man comes to the physician because of slowly enlarging, painless lesion on the bridge of his nose. He first noticed the growth approximately. Physical examination shows 0.7 pearly papule with prominent branching telangiectasias. What is this? This is basal cell carcinoma. What is the most important risk factor for the basal cell carcinoma? Exactly, sun exposure. So the correct answer would be chronic ultraviolet exposure. So it gives the same meaning. Nice. Okay, before we finish, can someone tell me 4 cancers associated with EBV? Amazing. Nasopharyngeal carcinoma. What else? Burkitt. Burkitt lymphoma. Primary CNS lymphoma. Amazing. What else? Hodgkin lymphoma. Let's make it 5. Amazing. Drasusi. Hairy leukoplakia of the mouse. Okay. Excellent work, guys. So that's it for today, guys. Thank you for attending today's session. If anyone needs anything, he can thank you. So if you want to continue learning like this with a personalized guidance, you can check the one-on-one tutoring for the Match Guy. So you can visit the website, see the packages, and we already offer a 30-minute demo session if someone is interested in the one-on-one tutoring. And if you are looking for an intensive structured review for the step 1, literally a review for all the high-yield materials in 1 week, check out the 7-day crash course on the Match Guy website. And if you want to keep testing yourself with the high-yield content, also we offer the Synapse QBank. So this would be your go-to resource for the high-yield materials, especially if you don't have time. This is 1,400 questions of the high-yield concepts. So if you don't have time, if you have like 1 month until your exam, I really recommend this QBank, guys. And we already also offer like 40 questions for free. You can do that on our website. Thank you, everyone. If someone still has any questions, I believe the video is posted on YouTube. So yeah, you can definitely message me there. Thank you, everyone, and have a great day. Bye.